Everyone, this presentation is on the treatment of hepatitis C virus infection. Table of content. We are going to be discussing the etiology of hepatitis C virus, the natural history of HCV, the signs and symptoms associated with HCV virus, the extrahepatic manifestation of HCV, how to diagnose HCV in a patient, counseling given to patients with HCV virus infection, the general management, and finally, the antiviral treatment given to patients with HCV. Hepatitis C is a viral infection caused by the hepatitis C virus. This virus primarily affects the liver. Hepatitis C virus infection can present either as an acute or as a chronic disease. And if most people that present in an acute state will eventually develop the chronic disease. And when this is left untreated or maybe treated late, can lead to liver cirrhosis or hepatocellular carcinoma. Hepatitis C virus is a global health concern with an estimation of about 71 million people affected worldwide. It is the most common cause of chronic liver disease in the US while transplantation. Between the year 2010 to 2018, the incidence of Hep C virus has quadrupled, especially among individuals between the ages of 18 and 39 years of age. In the US, about 3.7 million people are currently infected with HCV virus, and only about 52% of these 3.7 million are aware they have this disease. 37% have received treatment. The etiology of hepatitis C infection. Hepatitis C virus infection is caused by the hepatitis C virus. This virus is a blood-borne virus that is primarily transmitted through contact with infected blood, such as sharing needles with a patient who has hepatitis C. During blood transfusions, if the blood is not properly screened, you can also get it through sexual intercourse and through maternal to child transmission during childbirth. It is very important to know that you don't get Hep C infection through casual contact, hugging, or shaking hands with an infected person. After exposure to the hepatitis C virus, about 10 to 15% of individuals will clear the infection spontaneously. However, the remaining 55 to 85% will progress to chronic infection. And this chronic infection, when left untreated, can lead to liver cirrhosis and HCC, and eventually end-stage liver disease. The progression from acute to chronic and to end-stage liver disease varies among individuals based on several factors like their age, the genetics, and the coexisting liver conditions. The signs and symptoms of HCV infection. About 80% of people with acute HCV will have no symptoms at all. Some will have mild, non-specific symptoms that may likely go unnoticed, like nausea, vomiting, abdominal pain, loss of appetite. But as the infection progresses to each chronic stage, initially some patients may be asymptomatic, but as the liver damage progresses, they start showing signs of hepatic failure, like ascites, pale stool, jaundice, dark urine, easy bleeding, and bruising. Depression and anxiety are also common in patients with HCV. There could be extrahepatic manifestations of HCV infection. It could affect the kidneys, causing glomerulonephritis. It could manifest as an autoimmune disease such as thyroiditis, diabetes. It could manifest as a hematologic disease like lymphoma, like mixed proglobulinemia. It can also affect the skin, manifesting as porphyria cutaneous or lichen planus. In fact, if you see a patient presenting with lichen planus, you have to test the patient for HCV. In 2020, the CDC recommends HCV infection screening in all adults greater than or equal to 18 years to be screened at least once in a lifetime for HCV. Also, all pregnant women are to be screened during pregnancy. People with HIV, hepatitis B are also recommended to be screened at least once. And you can screen them using the viral HCV by checking for this HCV RNA. And if it is positive, you can go ahead and do the PCR. Why do we need to evaluate patients before treatment? We need to evaluate patients before treatment first to assess the extent of liver damage, to find out if this liver is already fibrous, if this patient has cirrhosis, if this patient already developed cancer. We also want to find out the viral genotype. Hep C virus has about 5 genotypes. We want to find out the genotype your patient has before you commence treatment. You also want to find out the renal function of this patient because this is going to help you in selecting the optimal antiviral therapy for this patient. You want to find out if there is any comorbidities this patient has, such as the extrahepatic manifestation we talked about, like the glomerulonephritis, the autoimmune diseases. This will also help you when choosing your antiviral therapy. You want to find out if this patient has HIV or hepatitis B virus, because sometimes most treatment used in treating Hep C V will go ahead and cause hepatitis B virus reactivation. So you want to find out this first before commencing your treatment. You need to screen your patients for depression and anxiety because depression and anxiety are one of the signs and symptoms of HCV virus infection. So you have to counsel your patients and make sure they're not depressed and they're not anxious. Some individuals with HCV infection may also have issues with substance use. So you need to counsel such patients on substance use treatments available for them, like opioid substitution therapy and also psychiatric services. HCV is primarily transmitted through exposure to infected blood. You have to counsel your patient on the specific routes of transmission and give them advice or measures to decrease the risk of giving it to other people. You also have to educate your pregnant women, not just pregnant women, all women, that HCV can be transmitted from mother to child during childbirth. It is important to know that active injection drug use is not a contraindication to antiviral therapy as long as the patient wishes to be treated and is willing to and able to adhere to the monitoring during treatment. You have to counsel your patients on their diet and their lifestyle choices. You have to encourage total abstinence from alcohol. You encourage weight loss in patients with obesity and also encourage smoking cessation in patients who smoke cigarettes and marijuana. This will help to slow the progression of the liver disease. Antiviral therapy is the mainstay of treatment of Hep C virus, but there are other general management involved, such as avoiding harmful drugs like NSAIDs, reducing the intake of acetaminophen to like less than 2 grams per day. Patients with advanced liver disease like fibrosis, complications like ascites, esophageal varices, hepatic encephalopathy, you also have to monitor them with labs. You check their albumin, check their prothrombin, check their bilirubin with labs to make sure the patient doesn't deteriorate. You encourage those who are not immune to pneumonia and hepatitis A to get vaccinated. Treatment. All patients with detectable level of HCV RNA for over a 6 month period should be considered for treatment. And our aim is to eradicate this HCV RNA and reduce liver-related mortality and morbidity. And how do we do this? We do it by checking what we call the SVR. SVR is sustained virologic virologic response. So it is a state whereby we are not able to detect any HCV RNA in your system after receiving 12 weeks of antiviral therapy. And when a patient achieves this SVR, it is associated with reduced morbidity and mortality, and also reduced complications. Antiviral selection. Selection of regimen for use is also very important in managing HCV. We need a regimen that is highly effective and and will be well tolerated by the patient with reduced adverse effects. You need before you select a regimen, you have to find out the genotype of your virus. So you need a regimen that will be able to take care of the genotype your patient have. You need to know if this patient is treatment naive or treatment experienced. Treatment naive patients are people that are being treated for the first time, while treatment experienced patients are patients that have been treated before and either relapsed or we are reinfected with the HCV. You have to find out if this patient has liver cirrhosis, cancer, or fibrosis. And the most important is the cost and the availability of the regimen you are selecting for your patient. Will this patient be able to afford the medication? Before now, we treat Hep C virus with PEG interferon ribavirin, but the direct acting antiviral therapy are now the treatment of choice. Why? Because they do not need frequent monitoring and it can basically treat all genotypes and with reduced adverse effects. We have the NS5/4A protease inhibitors like the glaceprevir, the grazoprevir. We have the NS5A inhibitors like the daclatasvir, the velpatasvir. We have the nucleoside polymerase inhibitor, the NPI, like the sofosbuvir and the non-nucleoside polymerase inhibitors, the dasabuvir. All these are direct acting antiviral therapy. The AFFP have a simplified treatment regimen for HC virus infection and cirrhosis. We have two regimens. The first one is the Mavorix, which is a combination of glaceprevir and pibrentasvir. It can basically treat genotype 1 to 6. It is very expensive. It is $25,000. You take about 3 tablets a day and it lasts for like the treatment lasts for like 8 weeks. The second option is the Epclusa, which is the sulforbusvir and velpatasvir. It could treat genotype 1 to 6 if you don't have any liver cirrhosis. But if you have cirrhosis, it can only treat genotype 1, 2, 4, 5, and 6 in patients with compensated liver cirrhosis. You take 1 tablet a day for 12 weeks. It is far more cheaper. It is about $11,000. Yeah. So for patients using the first regimen, the Meverett, you don't need genotyping because it can take care of all the genotype. For patients going for the second regimen, you have to type the patient to make sure the patient doesn't have the genotype 3 because this genotype 3 is resistant to this medication. And for the patient that you're treating for the first time, that is the treatment naive patients with cirrhosis, you need to evaluate them and make sure they don't have ascites and they don't have encephalopathy. Also, abdominal ultrasound within 6 months of treatment is required to exclude HCC. If your patient develops HCC, it is a contraindication to using this simplified regimen. You have to stop and refer your patient to a specialist. I pulled this table from the AFP website. The table basically tells you how to manage a treatment naive patient. You have to first of all assess the stage of the liver fibrosis and find out the genotype the patient has. If this patient has decompensated liver cirrhosis, you have to refer the person to an expert or a specialist. If no, then you can choose either of these regimens. and treat the patient as required. For treatment experienced patients or treatment failed patients, these are patients that have failed prior treatment with either PEG interferon and ribavirin or even a direct acting antiviral therapy. So how do you know this patient? This patient will test positive to HCV after 12 weeks of attaining the SVR. So it's either it is a reinfection or a relapse. So if this patient was initially cured of HCV and he got reinfected again, how do you treat the patient? You treat the patient with the same simplified regimen we discussed earlier, the Mevirate or the Eclusa. If it is just a relapse, then you have to do the genotyping. Probably the medication, the regimen you use did not cover all the genotypes. So you have to go ahead and do the genotyping, and then you have to refer the patient to a specialist as warranted. This table is how to manage patients who failed treatment initially. First, you have to assess the stage of the liver fibrosis. You have to know the treatment history, the kind of regimen they used, and finally, the genotype of the HCV they have. You also find out, do they have decompensated liver cirrhosis? If it is yes, then you have to refer them to a specialist. If it is no, you want to find out the prior treatment. Was it just with PEG interferon and ribavirin only? Was it a combination of PEG interferon, ribavirin, and a protease inhibitor? Or was it just a direct acting antiviral therapy? If it is with PEG interferon and ribavirin only, you go ahead and use the recommended regimen as shown below. This table is called the Chaipov classification for severity of cirrhosis. It basically helps you to check how severe your patient's cirrhosis is. It uses the albumin, the ascites, the bilirubin, the encephalopathy, and the INR. So it has a number of 1 to 3. So if your patient has an albumin of like greater than 3.5, your patient's the score is 1. If the patient has albumin of 2.8 to 3.5, it is plus 2. And any albumin less than 2.8 is plus 3. Same with ascites. Is there any ascites? If there's no ascites, it is 0. Mild to moderate will be a plus 2. And severe ascites is plus 3. Bilirubin, when it is less than 2 milligram per liter, is plus 1. 2, 2 to 3 milligram is plus 2. And when it is greater than 3, is plus 3. The absence of encephalopathy is plus 1, mild to moderate encephalopathy is plus 2, and severe encephalopathy is plus 3. INR of anything greater than 1.7, less than 1.7 is plus 1, between 1.7 and 2.3 is plus 2, and greater than 2.3 is plus 3. So at the end of this calculation, any patient that has a score of less than 7 has a compensated liver cirrhosis. Score between 7 to 9 is decompensated, and any score above 10 is severely decompensated. So any patient with score greater than 7 or history of decompensation is disqualified from getting the simplified regimen. So you have to refer this patient to a specialist. You also have to look out for possible drug-drug interaction while treating patients with hepatitis C virus. Medications like amiodarone are not safe to use when you are treating a patient with eclusa. Carbamazepine is not safe to use for both simplified regimen. Some of our diabetic medications, when a patient is taking any diabetic medication, you have to monitor the patient for hypoglycemia. Um, Herbal medicines, no, you don't use them. They are not advised to be used whenever you're taking all this simplified regimen. PPIs may be safe to use when you're using the Mevirate, but it's not safe to use when you're using a closer. Statins like the torvastatin and simvastatin and rovastatin, uh, may be increased. There may be increased level of this medication when using this when you're treating a patient with hepatitis C. So you have to watch out for myopathy. There may be increased incidence of myopathy and rhabdomyolysis. So you need to watch out for it. Warfarin, you have to monitor the for soft therapeutic INR because these medications can interact with warfarin. St. John wort is not safe to use while taking this antiviral therapy. Post-treatment surveillance. For patients with cirrhosis, without cirrhosis, you don't have to monitor them routinely. But patients with cirrhosis need to be monitored indefinitely for HCC and esophageal viruses. So you monitor them using abdominal ultrasound every 6 months. And you also do upper GI endoscopy every 2 to 3 years, depending on the first endoscopic result. But all patients with HCV is very, very essential to monitor them for early identification and management of hepatic and extrahepatic manifestation, for any reinfection or relapse, or other medical or psychiatric and social needs they may have. Patients should also be advised to avoid alcohol at all costs, avoid tobacco, to lose weight, and to avoid illicit drugs. This is the end of my presentation. Thank you very much.